and unfortunately, I cannot do that. I signed a waiver to share that for kind of a one-time gig, and the video recording people were supposed to actually turn the screen off when we were showing his past medical history, and they did not. So I guess I know you can see part of it, but let's just leave it at that. If you guys have any specific questions about his health care, please feel free to ask me. I'm happy to answer those. So for the sake of time, in terms of how do we deal with rude people or unmotivated people, if someone is rude to the point where you're not getting a word in edgewise and you don't feel like you're going to make progress, if you think it's a behavioral thing and it's a one-time gig, back off, acknowledge that they may be frustrated or upset, validate their complaints, and then leave. If you think that they're just going to be a chronic pain in the rear end, then you may have to change your approach. And, there are times where it might be just a personality conflict, and you're going to have somebody else come in and treat that person. That's not unheard of these days. In terms of unmotivated people, if you see some folks that are just chronically depressed or have major depressive disorder, and they aren't willing to try any of the things that you're giving them, you can lead the horse to the trough, but you can't make him drink. So give it your best go. Document that they're not making any progress, and that you think that some of their mental health issues are prohibiting them from making progress in treatment, and then discharge them. Mostly the reason being, some of these folks, they only have a set number of visits to come see a speech therapist or a specialty service, so let's not waste them on, trying to give them a pep talk. If they're not willing to work and they're not ready to rock and roll, send them away and bring them back when they are. Don't waste their time and yours. In terms of discharge processes, that varies from location to location, inpatient versus outpatient versus short-term nursing. That process will vary based on where you are at. From a medically complex person, where do you start? If you're talking about a hospital setting, an acute care inpatient, where they're going to start, the doctors are going to want to know how we're going to get this person fed. So that's where you start. How are they going to get their medication? How are we going to keep them hydrated? Can they eat? And then can they make their own decisions? Do they have decision-making capability? And you may be the person that actually goes up and evaluates them bedside initially, and then if you think they don't have all their marbles, then you need to place a neuropsych referral to make sure, unless there's a power of attorney or medical power of attorney, or there's a family member involved who can make the decisions for the patient. How do some people make a full recovery and some don't? That's always, the catch-22. And the answer is, some people can fall out of an airplane and land in a pile of manure, and somebody else can fall out of an airplane and land in a bed of roses. It's just, some of it is luck. And, pre-morbid mental health, medical status, how healthy their family members are, how hard they've abused their bodies their whole lives. Goals for treatment. Those of you who are in the medical center setting now, I'm sure are familiar with writing goals. We always want them to be measurable. We want them to have we have to quantify them in somehow. So, patient will make wants and needs known 3 out of 4 times with minimal cues across 4 trials. They have to be measurable, and you have to be able to track them over time. In a hospital, who makes referrals for speech? That's a good question. It varies, again, from facility to facility. Usually it's the hospitalist or internist, the medicine floor doctor will make the referral. And then what are the long-term prognosis for TBI? And people are still doing a lot of research as it pertains to, chronic side effects. Do they have a higher risk of developing some other comorbidities? Yes. Do we think it's because those people have executive function deficits and they engage in risky behavior and that leads to other things? Certainly. Genetics, again, plays a role. Do you have a history of dementia or any neurodegenerative diseases in your family? You got to look at the whole big picture. In terms of a typical therapy session, again, that can be very challenging. Usually 5 minutes or so of catching up, how you been, what's going on, and then from there it's getting into your goals, and then a summary session, assigning homework, scheduling the next appointment, things like that. Ashley, no, this session is not being recorded, unfortunately. How do other therapies work together? OT, PT, and speech. It's great if you're at a facility where you're allowed to co-treat. It can be hard in other facilities. If an occupational therapist is working on gait transfers, you as a speech therapist may be there, implementing some cognitive strategies to help them remember validation therapy, some of the things that Susan Miser talked about. So when possible, it's great to co-treat. It doesn't always work out that way. Can you modify treatment approaches? Absolutely. If you get started on something and you're noticing that the person's not making any progress, reevaluate. What are you doing? What is the patient doing? Why are they not making progress? Is there another technique? And move forward from there. So that's kind of a laundry list of things that I wanted to briefly touch base on with you guys as we wrap it up, kind of bring it all full circle. This first case, the main case that we're going to talk about tonight, I'll go ahead and read it aloud. You guys were given the paper copy earlier. This is what we were going to go over last week, and again, I am sorry for the technical difficulty. I do understand that Sally Disney you guys had the same problem earlier in the week, so again, I'm sorry for that. With that, let's get going. So, Mr. Mike Franz is a 68-year-old Army veteran, recently widowed with a live-in girlfriend. He's a high school graduate with limited post-secondary education. Mike worked in a print shop for 28 years prior to being forced into retirement. He has 3 grown children, all of which live outside the home and are married. In his spare time, he enjoys going out to dinner with his new girlfriend, attending events at his local Veterans of Foreign Wars, and spending time in the winter months in Florida in a rented apartment. Mr. Franz and his girlfriend Kathy come to your office today because his primary care practitioner told him to. Both Mike and Kathy are unsure why they were sent to you. The referral from Mike's doctor simply says evaluate cognition. Mr. Franz's medical history is significant for hypertension, which is pharmacologically managed, diabetes, and Meniere's disease. Mike has a family history of stroke and high cholesterol. Upon entering your office, Mike moves with associated arm and leg movements, no evidence of motor slowing. Mike reports no attention, memory, or concentration deficits. Further discussion with Mike and Kathy revealed new onset reliability on his global positioning system for directions to both new and old destinations. Spontaneous conversation with Mike reveals minor word-finding difficulty and 2 instances of self-corrections when discussing the name of his 5 grandchildren. Before administering the mini mental status exam, sorry, that was the SLIMS, I did change it. Before administering the SLIMS, Kathy reminds Mike to take his noontime medication. Results of the SLIMS are remarkable for a score of 24. Following decided to proceed forward with a test of memory, learning second edition. Results of the TOMO are significant for marked impairment in list learning, impaired association, and poor recall for stories. So, I just gave you the full overview. Let's go back into it in detail. So, before we get started, what's everybody thinking? Jana, awesome. Thank you for screen recording. Let's give him a score of a 24. So what are we thinking? Anybody have anything? Okay. So we're talking ENT referral because of the Meniere's disease. That's good. Somebody else says he's got dementia. What makes you think he's got dementia? Mild cognitive decline. Well, we know that. So let's go back. We'll go from the beginning. When you guys are doing case studies and taking your exam, this is how I would. These are the things. These are the keys that you need to be looking for. We talked about his education. He's a high school graduate with limited post-secondary education. So we already know which category to put him in on the SLIMS. Okay, he only has does not have a college degree. He worked in a print shop for 28 years prior to being forced into retirement. So we don't know if he was forced into retirement because he had poor performance, or because he couldn't remember to do his job, or because he had physical limitations, or because it switched owners and he had been there too long, so they wanted him retired. It had nothing to do with his merit. He has 3 grown children, all of which live outside the home and are married. So he's an empty nester. In his spare time, he enjoys going out to dinner with his new girlfriend and going to the VFW. He likes to go to Florida in the winter. He and his girlfriend come to your office because his primary care doctor told him to. Mike and Kathy are unsure why they were sent to you. The referral from his doctor said to evaluate cognition. Mike's medical history is remarkable for hypertension. He's got high blood pressure, which he takes medicine for. He's got diabetes. He's got Meniere's disease. He has a family history of stroke and high cholesterol. So he moves with all the associated arm and leg movements. So no evidence of motor slowing. So there's nothing about any tremors, any twitches, any abnormal gait issues. He himself, the patient says, no attention, memory, or concentration deficits. But while you're talking to Mike and Kathy, you realize that for some reason he's been relying on his GPS for new and old destinations. If somebody has to, for whatever reason, start using their GPS to find known locations, old destinations, that's a huge red flag. You following me now? Okay, he needs his GPS to get him to old locations, known places. What you guys are going to have to understand and how to be able to associate or differentiate is spontaneous conversation with Mike reveals minor word finding difficulties, so maybe some anomia, and 2 instances of self-corrections when discussing names of his 5 grandchildren. So he's got some word finding issues. He may be having a hard time remembering the names of his 5 grandchildren, which in the grand scheme of things is, again, new learning. The problems with new learning, problems with directions. Before administering him anything, his girlfriend reminds him to take his noontime medication. So he's not remembering to take it himself. He's got a score of 24, which we know with the high school education is mild neurocognitive disorder on the SLU-MS, I'm sorry. So then you decide to do the test of memory and learning. When you're finished with the test of memory and learning, you see that he's got marked impairment in list learning, impaired association, and poor recall for stories. Those characteristics are hallmark for some of our neurodegenerative diseases, and it's your job to know what those are. Does anybody have any sense of what those are the hallmark characteristics for? Talking about his language. What does his language show you? Bueller? No one? Okay, come back to it. So, what is your clinical interpretation of the above information? So, some people are saying signs of cognitive deficits, you've got dementia. That is not good enough for the final exam. I want to know what kind and I want to know why. I want to know where it's located in the brain, okay? So, we'll have to come back to point 1 because we're not able to answer it just yet. To whom would you refer? ENT. That's an appropriate. Is the naming of grandchildren learning? It's memory. If he can't remember the name of his children, Jennifer, naming, recent memory.
Is it right hemisphere?
Well, we'll get into that. Okay, so to whom would you refer? We already know ENT. We don't quite know if we need to go anywhere else yet. What is your role as the SLP in Mike Franz's care? Well, yes, neuropsychologist. It doesn't seem like he has it together. No, it doesn't. I thought you said learning. I was confused. Sorry, Jennifer. I probably did say learning. It's new. It's new information. It is new learning. It's newer information. So his grandchildren is newer in his learning schema than the name of his past wife. So, are further assessments more warranted? If so, what might you guys consider evaluating? What will be your theoretical framework for implementing treatment? So somebody already said that we would send him to a neuropsychologist. That's probably what I would do. Although I'm already thinking of what's going on because I know how he did. He's got impaired list learning. He's got impaired word association. Those are hallmark characteristics of Alzheimer's disease. And you guys will have to know that. Based on the information I gave you in this test, in this case study, you should already be thinking Alzheimer's disease. Okay. What and based on that, based on your knowledge of it being Alzheimer's disease, what theoretical framework would you implement for treatment? Anyone? You're going to do drill and kill for someone who has Alzheimer's disease? No. Let's see. What approach
Will we
are you?
do compensatory?
Yes, that's exactly right. That is exactly right. Will you recommend further treatment? If so, what will be your focus? So this is a tricky one, and one I will expect you guys to have the insight. If we're going to do compensatory therapy, we're not going to do drill and kill because he's got Alzheimer's. Okay, so what can we do? We can do memory books. We can do validation therapy. It'll be based on what his specific complaints are. So we already know that he has having problems with directions. He's having maybe some issues with his grandchildren's names, and he's having problems remembering to take his medication. So all of those things could be treatment ideas, could be areas of focus for your treatment. Please attempt to write 3 treatment goals with measurable outcomes. So Mike will take his noontime medications with minor scaffolding with the assistance of a pill organizer and an alarm. Okay, so if he's not quite yet totally demented and he's reliance on external organizer like electronic, yes. So those are the types of goals we're gonna wanna generate. How will you track his progress in treatment? So we need to give these individuals, we need to give Mike and Kathy the tools they need to succeed, and then we need to send them on their way, right? So we'll find out what areas he really needs help with, and then we'll modify his home environment. We'll give Kathy the education that she needs to help improve his quality of life and to keep him as independent as possible. And then we'll discharge him once those goals have been met. So once we give him some strategies to help remember to take his medication and some strategies to remember his grandkids' names, so, a memory book, then we discharge him. But we're not going to keep this cat on caseload for years to come because he's only going to continue to decline. So, like I had mentioned earlier, neuropsychological changes in Alzheimer's disease. From a memory standpoint, memory deficits affecting information acquired in the recent past are seen in early Alzheimer's disease and are manifested by difficulty learning new material such as word lists, paired word associations, and stories. Retention of newly learned material is difficult, and performance in delayed word and delayed visual recall is poor. Remote memory is less impaired initially, but deteriorates with disease progression. And you guys have all this information. This is all old news from the Alzheimer's lecture. Language. Got word finding problems. Self-corrections often result in inappropriate responses during conversation. Topic digression is likely. So I gave you all that information in the case history. Those are hallmark characteristics of Alzheimer's disease. Visual spatial deficits. They lose their way while driving. Well, we already know that because he's got to rely on his GPS. The motor is remarkably intact in early stages. Motor restlessness is noted and expressed through idle pacing. Limbs may be rigid and contracted as the disease progresses. So that's what we maybe think he has. We send him to a neuropsychologist. The neuropsychologist says, yes, maybe that's what's going on. The neuropsychologist then sends him to the neurologist and says, what new experimental drug can we put this cat on to slow disease progression? Move on from there. The rest of these slides I pulled from Susan Miser's. So if I ask, got a question? If I ask you in the final exam, what are some of the approaches to dementia evaluation? This again is in Susan Miser's lecture. You guys can pull this information, so you know what to expect or what to do. You already know what the spheres of cognition are. That was a test question previously. What's the role of the speech therapist in this guy's non-acute care in his home? Okay. These are some realistic questions that you may be able to answer, or you may ask a patient. So, like if you guys were trying to think of treatment goals for Mr. Franz, you may think, What was he able to do before that he wants to be able to do now? Well, he might want to know the names of his grandkids. He might want to be able to get to the VFW. He might want to remember to take his own medication. Okay, those types of things. This is, again, copy and pasted previously. If we were going to do restorative versus compensatory, if this cat didn't have Alzheimer's disease, if he had something else, you might want to do more of a drill and kill or a restorative approach, and you're going to have to tell me what you're going to do and why. And as you guys well know, it's not always mutually exclusive. These cases can sometimes be both, but if you're going to pick both, you're going to have to be able to tell me why. Sometimes I find that folks will say, well, I would do a combination approach, but then their justification for doing one approach is terrible, so then you don't get credit. So make sure whatever you pick it and stick with it. Okay, compensatory again. So I'll review. So communication targets, communication, orientation and memory, safety awareness, modification of the environment, caregiver training and discharge planning. Somebody said a referral for social work service. That's a great idea. I'm just going back. So, Jennifer, did you say? No, Melissa, maybe you said social work for grief response. That's great. That's very insightful. Although maybe not quite yet, because we don't. Jennifer said it. So we might not quite do it this early. We would want the confirmation from neuropsych before we send anybody to grief counseling, because we wouldn't want to send them to grief counseling if they just had a vitamin B12 deficiency or something, and their memory impairment can be assisted with that. Okay. Cognitive issues. Trying to advance the slide here. Cognitive issues in home care. Again, this is from Susan's. Home modifications and equipment. So in Mr. Fran's, home modification, I may recommend a pill organizer with an alarm. Okay. Medication, who's responsible. He was in the very early stages, so some of these things don't get as in depth. So we may want to evaluate receptive and expressive language, verbal and nonverbal communication, functional reading and writing, and what skills does he have that are intact? Okay. Treatment ideas for word finding. So he did have some anomia. There's parts of the body, items for grooming, TV remote, call light, medical tests, medical professionals on the team, names, names, goals for the day on a whiteboard, standard word finding drills, and advanced drills like convergent, divergent, and crossword puzzles. So all those things, again, are from Susan Miser's lecture. They're just giving you an example of how to pull it all together from the very beginning of our semester to now. Okay, these are external aids that we can use. Does that make sense to everyone? What I'm expecting, the depth. Yes. So the next case study I have is a little bit longer, and this appointment is can we have access to this PowerPoint? Yes, Jana, I'll send it out. Referrals and further assessments warranted the same. No, not really, because further assessments would be what would you do, right? What evaluations would you do? Referrals are who we're going to send them to. We said ENT and neuropsych. Those are two very appropriate places. From an assessment standpoint, would you want to assess their attention? Would you want to assess their language, perhaps? Okay. Yep, good question. All good questions. I want to give before we get started in the next case, if we have about a half an hour left, I want to make sure that everybody has an opportunity to ask questions before we get kicked off of this line. So I'll give everybody a chance to kind of type in. In terms of the final exam, they're going to be 2 large case studies, kind of like what we just did, 2 of those. And then a couple of smaller kind of mini case studies, a couple of those that are not nearly as in-depth, just like short answer maybe. And then in terms of new learning, there'll be multiple choice, short answer, fill in the blank, true, false, the same kind of deal that you're used to. As far as the platform, I'm not positive that it's going to be online. I'm having a hard time getting some of the questions for the case study to sync. So I'm not sure how to do a platform where you have the case study and then are able to have to answer questions about it, because if the questions go out of order, then we're screwed. So what I'm thinking about doing is just have it be paper-based, email it all out in paper-based, and have you send it back. But I'm not sure, so stay tuned for that. And as soon as I'm trying to work with somebody at the university to help me improve the design of the exam. So as soon as somebody gets back with me, I'll let you guys know. But those are usually some common questions. Nobody has any questions?
I have a question.
Let's hear it.
When we're working with patients who have Alzheimer's, a typical deficit is category fluency, and the strength is phonemic fluency, correct? In the early stages. Is there any reason to do intervention when it comes to category fluency, or do we try to reinforce phonemic fluency along the way to try to maintain those strengths? One would be obviously a means of maintaining strengths, and then the other one would be rehabilitation, but that really wouldn't work for someone who is progressively worsening. So do you have any advice as to how we would do intervention when it comes to those areas of language?
I guess my big question is, and how is it manifesting itself clinically? So you're talking about semantic categorization or phonemic, things like that, but really what's the person having a hard time doing? What is it that they need to do?
Okay, so if we're talking about category fluency, like just categorizing in everyday objects.
Okay, but why are we doing?
Well, that's my question. It was something that was done at my last site, and there are oftentimes, I'd look at what I'm seeing, and I'd be like, I don't really know how this is applicable to, everyday life. So I'm just wondering if it's really something that you would do, and if you can give an example of what you might do with somebody who has Alzheimer's.
Okay, so I would never say that what somebody else's treatment plan is bunk, but what I will say, and I think you guys probably heard on some of my lectures, that I have a real problem with people, quote unquote, doing therapy with demented, especially, advanced stage dementia folks, right? There needs to be a means to an end. You need to be improving their quality of life. We're modifying the environment. We're giving them the tools that they need to remain independent. This is about line, but in terms of a treatment, if you want to do category fluency, if we're talking about like food items, and you want them to be able to pick out their breakfast, if you gave somebody, okay, if we gave the Alzheimer's person a menu, just a menu in general, and there was breakfast, lunch, and dinner, we would want them to be able to categorize what items are most appropriate for breakfast, what items are most appropriate for lunch, and what items are most appropriate for dinner. So that would be kind of the categorization, something that might be functional for them to help them order their meals. Does that make sense?
Yes, it does. Yes, it does. And then as far as phonemic fluency, that doesn't really seem to have much of an impact on ADLs. I hate it, again, because I don't want to be, I would be ticked if somebody was bad-mouthing my treatment intervention, and without really knowing the person or knowing why they were working on it, it's hard for me to say, but... Right, I'm gonna tell you that I haven't seen the phonemic fluency, any kind of intervention when it comes to that, but it is on the MOCA, so, is that just for purpose, I'm assuming that's just for purposes of differentially diagnosing the cognitive impairment. So like phonemic fluency, the phonemic task is on the MOCA, for example, but I think the category fluency is on the slums, correct? So it's just kind of like a little confusing as to why it's not addressed on both.
Well, they're looking at language is what they're looking, and that's really what they're looking at to see if there is a deterioration in language. And language can also be a pre-morbid estimate of IQ as well, so that has something to do with it.
Okay. All right. I was just curious. It was something that I had seen it a few times as far as the category fluency goes, and when you're talking about animals and things like, it just doesn't apply. So you want to make it relevant, and and so sometimes it's hard to get creative in that respect when you're in this environment. So I was just getting your opinion on that. So thank you.
Not only that, functional items in terms of categorizing like if you and your patient were going to go take a bath, what items would they have to take with them? And you can the items out on that table. Are they going to take the remote into the bathroom? No, they need to have their soap and washcloth, and so those kinds of things are functional. Not, if you take an Alzheimer's patient, you're having them figure out how many animals they can come up with, or how many words that they can come up with that start with the letter S. Like, I think you're tinkling in the wind, but
right. That's what I figured. Yeah, exactly. Okay.
Yep. All right. What else? What other questions can I answer for anybody?
With some of those techniques that I'm not sure who was asking the question, but would they be appropriate if we were trying to potentially someone who is medicated in the early stages, maybe like stage 1 or stage 2, would that be something that you would want to try to do to help keep things going, to possibly eliminate or prolong the memory in those stages?
I see what you're saying. It's a good question, and my answer would be no.
Okay. So once you have that diagnosis and you know what is going to follow in terms of those stages, basically we want to take it where we are, look at it as all compensatory so that everything is functional, of course, for daily quality of life.
Yeah, and that might change based on, as the research continues to come out. And if we're talking about somebody who, is still working and is doing quite well with their ADLs, you're going to want to do your best to keep them mentally active. And I don't know if your idea of keeping them mentally active is having them do semantic and phonemic categorizations, by all means. But I really struggle with doing drill-based activities like that aren't applicable to that person's everyday life. So if the individual is still working and they're having a hard time, prioritizing their tasks at work, if you want to break down tasks into categories and do it that way because you want to keep that person working for another 3 months so that they can have a full retirement, let's try it. I'm game for anything, but don't be sitting there in somebody's room that's 89 years old and they've been diagnosed with Alzheimer's disease for 7 years, and you bring a book and we're going to categorize clocks and watches into time, mechanisms to keep track of time. Like, I'll strangle each and every one of you.
Okay.
It's got to be something that's very functional and applicable to that person's daily life. And if you can't figure it out what's applicable or important, then we don't need to be involved.
Okay, thank you.
Yep, good question. What else? Anything? Okay, do we want me to go on to the second case study? Try to muscle it out pretty quick? Okay, here we go. This time I'm expecting more interaction in terms of key things that I come across. What are some of the things that are jumping out at you in terms of impairment and what I'm looking at and what I'm giving you? So, real quick, Miss Abigail Smith is a 57-year-old female with a past medical history significant for repeated head injuries. Oh, man. As a result of her professional soccer career in Europe. Miss Smith is single and lives in a 2-story home that she shares with her sister. All bedrooms and bathrooms are on the second floor. Miss Smith works full-time at The Ohio State University as an assistant head coach of the women's soccer team. As an inpatient speech-language pathologist at the university hospital, you receive a consult to evaluate Miss Smith's ability to safely take PO trials following emergency surgery for a broken leg. Ruh-roh. Miss Smith's sister, Betty, reports Abby has been losing her balance recently and fell walking down the porch steps, breaking her leg in 3 different places. Betty also said Abby has been overwhelmed at work and has recently begun to confuse home versus away game locations. Miss Smith required prolonged intubation for failure to wean from the ventilator. Following self-extubation, Miss Smith presented with mild to moderate dysphonia, weak cough, and mild dysphagia requiring a modified diet of soft solids and extra-thick liquids. On your way to Abby's room, you overheard the nurse saying Miss Smith was going to be discharged to a short-term nursing/rehab facility. You are back to see Abby to assess diet tolerance. Upon entering the room, you observe Miss Smith eating her breakfast. Not previously noted, you witness what appears to be an awkward movement of her pointer finger, middle finger, and thumb on her non-dominant left hand. Upon further independent observation, you notice Miss Smith has very mild resting tremor in her left leg and very mild difficulty keeping food on her fork as she transitions from plate to mouth. As you begin to ask Miss Smith how her breakfast is, you notice she has no recollection of her time spent with you the day prior, despite reintroducing herself. You asked Abby how she was doing, and she said, "Great, just getting ready to leave the horseshoe and head out for training run with the ladies." All right, so I'm going to go back up here through the chat. You guys are blowing it up. That's great. That's great. That's great. Okay, so repeated head injuries is a flag. You got it. That is exactly right. We're thinking TBI, repeated head injuries. We're thinking TBI, losing balance, short-term memory problems, damage to cranial nerve 10 with swallowing problems, referral for OT due to difficulty with eating utensils. Huntington's, confusing locations, awkward movements of non-dominant hands, tremors, loss of short-term memory. Definitely referral to OT. Fluid aphasia, mechanical ventilation disruption. All right, so we are all over the place in this regard. So let's go, like we did last time, let's go back. Okay, so first things first. I did mention repetitive head injuries, okay? Also important, she's single and lives in a 2-story home that she shares with her sister. Guess what? She's got a broken leg. She's in deep doo-doo in that regard. All bedrooms and bathrooms are on the second floor. How is she going to go potty? How is she going to shower with a broken leg? Miss Smith works full-time at The Ohio State University as an assistant head coach for women's soccer. Okay. Her sister says that she's been losing her balance recently and fell walking down the porch steps. So she wasn't pushed, she didn't trip, she fell. She has had poor balance. Okay? But he also said Abby has been overwhelmed at work and has recently begun to confuse home versus away games. So maybe there's some mild cognitive impairment. Okay? We got some mild cognitive impairment. We've got a broken leg. We've got some confusion. Following self-extubation, she had some mild... Whoops. Sorry, I'm probably making you guys dizzy. Damn it, hold on. Following self-extubation, Miss Smith presented with mild to moderate dysphonia, not to be unexpected because she probably bruised her vocal cords when she self-extubated. Weak cough and mild dysphagia requiring a modified diet of soft solids and extra-thick liquids. Okay? Going to rehab. You're in there to see your diet tolerance, right? You think that Tina, you got it, lady. Okay. Upon entering the room, you observe Miss Smith eating her breakfast. Not previously noticed, you witnessed what appears to be an awkward movement of her pointer finger, middle finger, and non-dominant hand. We're talking about pill rolling here. Pointer finger, thumb, non-dominant hand. Pill rolling. After further independent observation, you notice Miss Smith has a very mild resting tremor in her left leg and very mild difficulty keeping food on her fork as she transitions from plate to mouth. So I've talked about a resting tremor. I've talked about balance issues. Those are all hallmark characteristics of Parkinson's. She has had repetitive concussed brain injury. So do we have Parkinson's as a result of multiple head injuries? Probably. fell down the stairs, and now she's got a broken leg. She's got confusion, so she might have some mild cognitive impairment. She has no recollection of the time spent with you the day prior. So maybe she's got some delirium, she's confused, she's not sure where she is, and she lacks total insight into her deficits. You asked how she was doing, and she said, great, just getting ready to leave the horseshoe and head out for a training run with the ladies. She's in bad shape, okay? Lacks insight, repetitive head injuries, resting tremor, mild cognitive impairment, some dysphagia. She lives in a 2-story house with her sister with the bedrooms and the bathrooms all on the 2nd floor. She's going to have to go somewhere other than home, which is why she's going to the rehab facility. What is your clinical interpretation of the above information? You probably got Parkinson's. Whom would you refer? Probably, who? Somebody had a pretty good one up here. Who would we refer her to? Neurologist, OT, yeah, good. Neurologist, physical therapist, yes, all the above. What role would you play in this care? Well, a bunch. We're going to be looking at her from a neuro standpoint. We're going to have to assess her cognition. We're going to have to assess her speech and language. And we're going to have to manage her dysphagia. What will be your theoretical framework for implementing treatment? It depends on what we're treating. If we're talking about her dysphagia, we're probably going to do more of a drill and kill. There's no reason why she can't strengthen those muscles to get better at swallowing post-extubation, but she's going to have some serious assistance doing it because she may not remember to actually follow the plan, right? So you can go ahead and rehab those vocal cords. Wouldn't it also depend on what her discharge plan? Yes, that's exactly right. And how much care she's going to have. Yes. Since she's going to a rehab facility, you're hoping that speech therapist is going to take over where you left off. That's exactly right. So what's your theoretical framework? From a dysphagia standpoint, I would say drill and kill. From a cognitive standpoint, I would say we need to do further evaluation, but based on her clinical presentation at present, you would lean on the side of compensatory. Will you recommend further treatment? If so, what will be your focus? Absolutely. We want to evaluate her cognition further on our final. If we have a patient like this, do you want us to mention the following or stick with the cognition? You should reference the dysphagia, Kylie. Good, that's an excellent question. Reference the dysphagia, but I'm not testing you on that. I'm testing you on the cognitive part. Good question. Goals. You guys will have to be able to write goals. How will you track progress in goals? If they're not meeting their goals, if they're not making progress towards their goals, then we got to discharge them. When will you know when to discharge the patient? When they're no longer making progress towards goals. So, talking about Parkinson's demographics, 1 person in every 1,000 risk for contracting the disease. 60 is the average age of onset. She's 57, but we're thinking maybe she has it as a result of her multiple repetitive concussive injuries. Okay. Speech symptoms, although we didn't talk about that really a whole lot, you want to evaluate that if you're thinking of Parkinson's disease. Melissa, try to give me a goal. You work for me. Somebody help Melissa out. Let's give an example of a good goal for this patient. It's got to be measurable. We've got to track it over time. We have to be able to quantify it. Somebody help her. Realistically, what would this patient to be able to do?
Would we want to include something with orientation to place and time?
Excellent. Who am I speaking with?
This is Leslie Bosley.
Leslie, that's exactly right. So how can we write a measurable goal that incorporates orientation into that?
Possibly Abby will increase the ability to orient herself to place and time with 80% accuracy over 4 consecutive therapy sessions or 3 out of 4 per therapy sessions.
That's great. Abby will identify day, week, month, time.
So if we, I don't mean to interrupt you, but if we know that, there's a sit, let's just say we have a standard let's just say if for our goal keeping ourselves, I know if I'm going to work on orientation to place and time that I'm always going to include those things that you say. Do we have to put that in the goal?
I'm not quite sure I understand what you're asking.
Okay, like if I know I'm going to work with someone in the nursing home or rehab facility on orientation to place and time, and I'm always going to want them to tell me the name of the facility that they're in, the day of the week, the month of the year, the month, and then the year, and then like those standard questions. Can we use orientation to place and time, or do we have to list out the attributes that we will be measuring?
No, you're right.
Okay, I'm sorry for interrupting.
Oh, that's good. No, Kylie actually did a great goal, and I just modified it a little bit. So she'll orient herself times 4 with 80% accuracy. 80% accuracy of what, though? For increased integration into her environment across 3 trials with moderate scaffolding. So you could say you want the patient to be oriented to location 3 days a week across 3 weeks, right? That's as simple as it gets. We don't have to use all these fancy terms, but you've got to be able to track it, and especially for those of you that are going to work in the private sector where billing is involved in insurance. If you don't have measurable goals and that patient's not making progress towards those goals, you're going to get kicked to the curb. So we really have to say what we're doing and how we're measuring it. So, and then once the goal is met, across 3 trials or across however many trials, then we're good to go. Very good question. We're running short on time, so I'm going to keep powering through this here. So you guys know the speech symptoms. Be familiar with those. If I talk about her vocal quality, those could be a treatment goal if you wanted it to be. Post-encephalopathic Parkinson's, other causes, boxing, head injury. In her case, it was head injury. Okay, targets for orientation and memory. Again, this is from Susan Miser's lecture. Make yourself familiar with those. Tools we can use to help these folks. Okay, those are all external. So, the exam is comprehensive in nature in the sense that, you have to understand everything that we learned from session 1 to be able to integrate it into the final. But I'm not going to be asking piddly-ass questions, from PowerPoint 1. What you do need to pay particular attention to is kind of the headings in some of the PowerPoint. I talk about the mechanism of injury. I talk about those types of things. If I'm asking you what the mechanism of injury is, you have to understand what mechanism is. What are the mechanisms of injury, and discuss them confidently. Okay, so be familiar with the verbiage. Sometimes students don't understand what I'm asking. Anybody else have any questions for me? No one? No, I will not be posting any more case studies. No, we're not going to reference. Nope, there's no way to access the other tests for study reference. You guys should still have your feedback. You should now, Natalie. Try again. Linda was able to access it. You might want to touch base with her. That's a good question, Melissa. It will be timed regardless. Even if it is a paper-based exam, I'll send it out like at 7 a.m. on Saturday morning, and it has to be sent back to me, or it has to be in the Dropbox by 11 o'clock. You'll have 3 hours to take the exam by 11, or else it won't be accepted, and it'll be timed. So if you're too late, then you won't be able to submit it, just like your short rates. Any other questions? All right, Jennifer. Yes, they have been. You should have it graded in Blackboard. Is everybody able to see their grades in Blackboard now that one individual brought that up? Can everybody see their SLU MS assignments, their grades? Okay, yeah. All right, if you don't have a grade, it's probably because you did not submit it on time and then it wasn't graded. So email me privately and I will look into it. Any other questions? All right, ladies. It's been real. I hope. Just try to open feedback and it's not working. I had one student email me earlier today and said that it was working, so yeah, okay. That's now 4 students who it worked, so I'm not sure why it's not working. Chelsea, you could try to refresh it or open it up in a different browser on a different computer and see if it... No, I had to switch browsers the last time. No problem. Okay, if we don't have any other questions, then I've enjoyed teaching this class with you guys. I hope that you learned something new. As always, if you have any other issues as your career unfolds, please feel free to shoot me an email. I have lots of students that ask questions every once in a while, so